Good. Okay, just thank you everyone for joining us for today's Grand Rounds. Thank you to Dr. Bodeman for letting me hijack Grand Rounds today. I just want to remind everyone to use the Q&A box, and we will ask questions towards the end of our Grand Round speaker, and also to mute your devices too. So I'm delighted to introduce Dr. Jonathan Ripp, who's a professor of medicine, medical education, and geriatrics and palliative medicine, Senior Associate Dean for Wellbeing and Resilience, and the Chief Wellness Officer at the Icahn School of Medicine at Mount Sinai. Dr. Ripp received his undergraduate and his medical school degrees from Yale. He completed his internal medicine residency training at Mount Sinai Hospital in New York. In his current role as Chief Wellness Officer, Dr. Ripp oversees efforts to assess and provide direction for system and individual level interventions designed to improve well-being for all students, residents, fellows, staff, and faculty in the Mount Sinai Health System. He's a former Associate Dean of GME for Trainee Wellbeing within the Icahn School of Medicine at Mount Sinai's Office of GME. In that capacity, he served to help spread well-being initiatives across the training programs at Mount Sinai, and that includes 2,000 residents and fellows. He's a core faculty member for the Internal Medicine Residency Training Program. He's co-founder and director of CHARM, the Collaborative for Healing and Renewal in Medicine, an international group of medical educators, academic medical center leaders, experts in burnout research and interventions, and leaders all working to promote learner and trainee wellness. He's been recognized in this area of expertise, participating in ACGME, ACP, and the National Academy's Action Collaborative on Clinician Wellbeing. He has published and lectured extensively on primary area of research, which is physician burnout and well-being, and we're delighted to welcome him here today to Grand Rounds to speak. So apologize for technical difficulties, but we will go ahead and get started. John?
Thanks so much, Dr. Menard. It's really a pleasure to be with you all. I'm delighted to be with you, and apologies for the late start. Nothing like technical difficulties to influence your well-being. So, but we're here, we're together. I will make sure to get through my content and save time for some Q&A at the end. Happy. I think, are you going to be advancing the slides for me? And if so, can you go to the second slide?
Yep, there we go.
Okay, great. And I'm not seeing the slides, but that's all right. I have them up here, and we're gonna make this happen. So if you're on the objective slide, which is slide 2, what I hope to do for you in the next little bit is
we're not seeing any slides.
Oh, let me get. Okay, that's me. I guess I need to.
Happy to share your screen.
Yeah, sorry about that. I will screen.
That's all right. That's all right. While you're pulling that up, I will just share with you what I have in mind for you today, which is first I'm gonna talk to you about what the factors are that affect physician well-being. I imagine many of you, and there we go. I imagine many of you are familiar with this. We're going to talk a bit about COVID-19 and how it's impacted the emotional well-being of the healthcare workforce from our perspective here in New York City, which I imagine has both some similarities and differences from the experience that you had. And I think, every place in the country has experienced it a little different, and there's commonalities and differences. We're going to talk about the changes, sort of what a lot of us are now referring to as the COVID pivot, sort of what are the new influences on clinician well-being in the context of COVID, and now where we're at least in New York, now that we've passed the surge and facing potentially some increase in cases. We will talk about how to make the case to continue to prioritize physician well-being. There's an argument to be made that now more than ever, it's important. And then just I hope to finish off by sharing with you, make you more familiar with some of the resources available through a lot of efforts. There's a lot of efforts happening nationally. So if we could go to the next slide, please. For some of you, I think perhaps you've seen this figure that I just want to use as by way of background to get us starting to think about all the many drivers that impact well-being. And really, I think the key that the takeaway from this slide is that this is a complex that well-being is complex, and there are many drivers at work as it relates to the influencers of well-being for physicians, and you can really extend this to other members of the healthcare professional workforce. And much of this has to do with a variety of dimensions that affect one's ability to, quite frankly, get the job done. You know, are you enabled with the correct resources and systems that are efficient, or are those barriers? Do you have excessive workload and job demands, or are they right-sized? How much control and flexibility do you have on your day-to-day? That will certainly influence your well-being. And of course, we know now more than ever with our ability to have our work and our lives merged, nearly all the time, the ability to separate or integrate our work lives and our non-work lives promotes a number of challenges. And then there's a lot to be said about the culture within which you work and the community within which you work. These have huge impacts on your well-being. At the center of all this is the ability to derive meaning from work. What I remain optimistic about, despite having been someone who has studied burnout in physicians for 15 years, is that we still are part of a profession in which there is a great deal of meaning we can derive. And so this figure captures that by showing you how when all these driver dimensions are optimized, we actually can be engaged, we can feel vigor and dedication, absorption with our careers. And we should remain fortunate, that feeling fortunate about that, because we are lucky to be in that type of profession, while at the same time we know that there's a lot of barriers at work here that can potentially drive us towards burnout. Next slide, please. The attention to well-being has, prior to COVID, was really mounting and gaining national attention, international attention. And positions such as mine, chief wellness officer positions, were really and continue to be named and reflective of large institutional commitments to well-being. And I believe this slide, this figure, captures perhaps why the momentum was mounting, because there's been an increased understanding and evidence in the literature and recognition that burnout, really the opposite of well-being, it affects the healthcare workforce, affects clinicians, both on a personal and a professional level. The personal level are, all those potential consequences such as depression and substance use. It affects our relationships. We're concerned about physician suicide being higher than that of in other professions. And so lots of really important personal reasons to pay attention to this in and of itself, but also a recognition that if you want to run a healthcare system, if well-being is not one of your strategic priorities, the well-being of your workforce, then it's going to affect certainly what are a lot of the other strategic priorities that we see in the healthcare workforce, whether it's quality of care, elimination of medical errors, patient satisfaction, productivity, and then retention. We simply know that physicians who are burnt out are more likely to report wanting to leave the profession. Next slide, please. So we at Mount Sinai, when I came into my role, underwent a process of identifying our own model for healthcare worker well-being. And I imagine some of you have seen, there are many models that are out there. Some are quite simple, some are quite complex, that attempt to explain what it is that goes into the derivation of professional fulfillment and meaning in work. We went through this exercise, my team and I, at the start of our office, not to generate our own model that we wanted to tout above others, but really to create a model for the way in which we think internally about the areas that we want to try to have influence, and create a figure that describes the relative weight of those areas. And so it's not an accident that the two biggest wheels here, which when are all turning in the right direction yields professional fulfillment, it's not an accident that the two biggest wheels are workplace culture and workplace efficiency and function. It really remains our belief that it's the system within which we work that that enables us to derive meaning. Again, based on that premise that we're already in a career through which there's a great deal of potential for us to find meaning in our work. We just need to be enabled to do so through an efficient workplace and a workplace that promotes a culture of well-being. Next slide, please. Mm-hmm. So I want to, with that background, I want to shift gears and speak to our own experience. You know, we had set up our Office of Well-Being and Resilience prior to the COVID pandemic, rearing its head, and had already been up and running for about 2 years when we first started seeing COVID cases back in March. And so I want to share with you what it was that we saw here in New York. We saw a very rapid rise in cases and a large, at the time we were speaking of ourselves as being the epicenter of this pandemic. And there was sort of matching the pandemic curve. We saw different stressors emerging as the major source of anxiety and distress amongst our workforce. And we utilized the infrastructure that my office had put in place to understand the needs of our workforce as it related to their stresses, so we could, in as close to real time, address those needs as they were arising in the midst of a crisis. And so certainly in the beginning, and this I'm sure will resonate with many of you, we, as the cases were quite few, but we had, society had shut down, so to speak, and really there was great disruption. Much of the fear and stress was around meeting our basic daily needs. And so a lot of concerns emerged from our workforce about how am I going to get safely to work? Where am I going to find my next meal? Who's going to take care of my kids? And then also when you talk about basic needs, your own safety and security. Am I going to be safe? Am I going to be able to keep my family safe? And so that was the first major stressor, but things evolved very rapidly. And as the cases began to shoot up, what overcame that, as particularly as we put a number of resources in place, was uncertainty. And I think certainly we are, the impact of uncertainty on our stress and anxiety is again what we're seeing right now with a great deal of uncertainty. So, but in the midst of the crisis, as numbers were rapidly escalating, it was all about, am I going to be able to manage the workload that is coming my way? If I'm redeployed, will I have the skills and support to do the work? For some who were sidelined and maybe their practices were shut down, there was the guilt of whether I could be doing enough. Will I be supported? Will I be able to make difficult decisions, discussions around, potential shortages of resources? And so uncertainty was the major stressor as cases were rising. When we reached our peak and then came down the other end and cases dropped, it was really a time where we were beginning to process what we had been through. And this is captured in the research looking, some of which has come out of the Center for the Study of Traumatic Stress, which shows that in the midst of a crisis, people rally, they heed the call, and they get the job done, but they kind of table their processing of it until afterwards. And so what happens when the cases drop, and we see this, is that that's the time where people begin to take a breath. They grieve for their losses, of which all of us experienced in one shape or another, some more closely and personally than others. And so that's when people really began. And I would argue that we're sort of still in that phase. If you layer upon it all the other societal stressors that arrived at the same time, including the attention to racial injustice, and now, looking at return to school and things like that, there's just an enormous amount of stress and processing of these really traumatic experiences. Next slide, please. So to match those stressors, we at Mount Sinai put in place strategies to meet those stressors. When it was a fear for meeting basic daily needs, we, like many institutions, I imagine yours as well, put into place access to those resources, whether it was food, whether it was childcare, whether it was transportation. In the case of concern about one's own safety, clarity around PPE and procurement of those resources. When uncertainty is the diagnosis for the cause of anxiety, the treatment is communication and provision of knowledge and information. And we did that through regular, authentic, transparent communication in a variety of settings, whether it was emails, town halls, and a variety of other platforms. And then as we entered the phase that I would argue we are in now, where people are processing and grieving, it's all about sort of providing psychosocial mental health support. Everybody who's gone through this needs support in some way or another. Some people will be really affected by this and may benefit from mental health treatment. So our ability to deliver that in the midst of the crisis and onwards has been central to our strategies. And we've done that in a variety of ways: virtual support groups, crisis lines, telepsychiatry, what we called mental health PPE, which was our proactive mental health practitioners going out and seeing how the frontline workers were doing and asking them how they're doing, and then providing resources, what we called frontline relief, in the places that people were working, so that they wouldn't have to go far to get support. Next slide, please. I put this here just to show you a resource you may find interesting. We, since we went to a lot of effort using the infrastructure that we had put in place for our well-being office prior to COVID, we used that infrastructure, those individuals who were part of our cadre who could give us information about what people were expressing and feeling, what their major anxieties were that I just spoken to, and partnered with colleagues at Stanford who there conducted focus groups and really identified sort of 5 main requests that the healthcare workforce was asking for as it relates to their anxieties in the midst of the crisis. And you see that in the left-hand column here, that they wanted to be heard, they wanted to be protected, prepared, supported, and cared for. And that was what we captured in this piece in JAMA back in April. Next slide, please. Another piece that we put in academic medicine speaks to sort of our comprehensive approach that I just outlined for you, which came out also in April, which characterized our attention to the emotional well-being of the healthcare workforce and how we went about identifying the major areas that we strategized and prioritized based on the needs. And you see here what may look familiar to some of you, what is a modified Maslow's pyramid, which shows really that, you know, in the midst of crisis, it's meeting those basic needs at the bottom. It's basics and safety, right? It's food and transportation and keeping safe. You can't really do much else when those aren't met. And so that is nicely captured here and speaks to our approach. Next slide, please. I spoke to you about frontline relief. This was a really wonderful partnership that came out. And I noticed that a number of other health systems have put this type of resource into place. And you know, it's not a one size fits all when it comes to supporting a large workforce. You know, some people will want psychosocial mental health support, but others will just want a moment of respite, or they'll want individual ways of handling their own stressors. And if the picture there looks like the rainforest, that is what it feels like when you enter these recharge spaces, these well-being centers that were also accompanied by snack stations. The snack stations have sunset. We don't have those anymore, but the recharge rooms remain. They're now called recharge rooms, and they were actually expanding them. They were made possible through a gift, and they were so successful. There was such great interest and feedback that we're now expanding those. And basically what they are these immersive spaces that utilize multiple elements: music, sights, sounds, meditative visual elements. And it's remarkable how, you know, within a matter of minutes entering these places, you sort of feel yourself calming down. And they've been very well received. And I definitely advocate for doing these. And they're actually not as expensive as you might think. You know, in these times, it's important to think about resources, but if you can identify space, and if we could identify space in New York City, where space is always a premium. You know, other places I'm sure can do this, just to identify a space and put in a few key elements. So these were great. We were really lucky to have these. Next slide, please. I mentioned the importance of communication when it comes to addressing uncertainty as a source of anxiety. So we put all of this up, our entire digital health team and website team sort of converged and put up a new website in a matter of days as the COVID cases were mounting, and categorized all of this on our COVID-19 staff resources website. There was a well-being staff page, and you can see here we kind of broke down resources based on basic needs and self-care, mental health and psychosocial support, and the on-the-ground support for the frontline workers. And so put all that on the website, which was critically important. It enabled us in short order to just direct anyone who wanted to know, you know, probably 90% of the requests we got and 90% of the information that people needed, we could just direct them to this one site and they could find it there. Next slide, please. So now I want to sort of transition back and use this figure here to sort of set the stage for where we've gone. So that was, you know, that was March, April, May. We saw a steady and continued low prevalence throughout the summer, which came as a very welcome relief for a beleaguered workforce. And so, you know, we had to kind of face this situation of what were we going to continue and what were we going to sunset. So as you can imagine, all of those resources that I shared with you required really a delegation of a lot of personnel and a lot of resources, a lot of financial resources. So, you know, we needed to sort of take stock on how they were being utilized and make decisions about what we would continue and what we would sunset. And so what you see here is where we are today. This is an infographic. I'm a big fan of these communication tools because it's an easy way to deliver a large amount of information. And this can be found at that web link that I've included on the bottom of the slide there. And it basically takes our workforce to a menu of options. It really is my belief, again, you know, stating that well-being is a very personal is very personal and is derived by a multitude of drivers that you need to have sort of a multitude of approaches to promoting. So we have a new Center for Stress Resilience and Personal Growth, which I'll speak to a little more in a moment. But we had existing resources that we, through my office and my role, a lot of what we do is in creating comprehensive and coherent offerings and then pushing those out to people. And so taking existing resources, but making people aware of them, whether it's your employee assistance program, whether it's your mindfulness, you know, individual resilience offerings, whether it's peer support, spiritual care, psychiatry. We even put our therapy dog on there, and of course the wellness recharge rooms that I spoke to. And so this is kind of the current state of affairs. Some of those things that were on my previous slides, like our 24/7 crisis lines, some of the more proactive mental health support that was going out to the COVID units have now sunset, and you know, we think appropriately so. They just we tracked their utilization and found that they were being utilized less. Next slide. So the new center that was put up as a result of what we went through is really, we feel incredibly fortunate to have this resource, but it's a group of psychiatrists and social work therapists who have been hired as part of a new center to provide treatment, screening, treatment, referral, and resilience training to anyone in our healthcare workforce as a result of having worked through COVID. And this will obviously remain. And so it speaks a little bit to what is it that motivates the formation, the development of resources to promote well-being. Sometimes it takes a crisis. Sometimes it takes a tragic event. We had actually identified on a faculty well-being survey done prior to COVID that about a third of our faculty surveyed actually felt they would have benefited from mental health services in the year prior to their taking the survey, but only about half of those actually did take advantage of services, and the other half said that they didn't because they either didn't have time or they didn't know where to go. So we had been advocating for creating services for our own faculty. This new center extends its offerings beyond just faculty, but it helps fill a gap we identified before COVID. And sometimes, you know, I certainly don't feel like it's taking advantage of a crisis. I think sometimes it just takes a crisis to elevate the platform a little bit. Next slide. I just include this on here for you because all of our resources and the process that we went through have been described in this toolkit, which is you know, entitled A Comprehensive Toolkit for Supporting Our Own During COVID-19, and it's downloadable and available, and you're welcome to peruse it and consider, you know, how and if what we did may relate to what you did, and obviously we can all learn from each other. Next slide, please. So the last thing I want to say as it relates to our experience with COVID before shifting to the final section of my talk for today is that what, you know, is a critical component of crisis response, particularly in that phase that I spoke of, where, you know, now we've kind of had a moment to breathe and process our loss, is memorialization, which is particularly challenging in a time of social distancing. But we did commemorate the loss of our own, and we did in fact lose many. We were 40,000 plus healthcare systems, so within that we lost many employees from multiple spheres, multiple backgrounds, not just clinical employees, but non-clinical as well. And so speaking to what I mentioned earlier, that everyone was touched by this, some in a much more personal way. Obviously, for those that lost these loved ones, we had a virtual memorial service, which was quite meaningful, and I think really important as part of the ongoing healing process for our entire community. Next slide, please. So in this last part, I hope I kind of set this up to continue to make the case for well-being. This is a slide that I've used many times when kind of making the case for you know, an organizational, institutional level commitment to addressing well-being. There's many arguments. There's many reasons to support it. Whether it's the regulatory environment. You know, if you have residents at your health system, then the ACGME mandates that you pay attention to their well-being. There's a business case to be made as it relates to many of the professional consequences of not addressing burnout. Of course, there's the tragic argument where, you know, suicide is higher in our workforce, and so we must pay attention to this. We have a moral imperative which is captured in this photo here, a picture of a trauma physician who is basically has broken down after losing an adolescent child who came in after a motor vehicle accident. You know, we can't be continuing to suffer alone. We need to continue to make sure that we're elevating awareness around the toll that our profession can take on some. And so these were the arguments before. If you can go to the next slide. I hope that, you know, by sharing with you our experience in New York City, I've only made more of a case why we need to continue to pay attention to the well-being of the workforce for all of those reasons, and now more, which is that we've been exposed to a communal trauma as captured in these pieces and more. I'm sure many of you have seen lots in the lay press and now emerging in the medical literature. Certainly we have unpublished data, which I wish I could present today, but it's currently under review. But nonetheless, we surveyed our workforce in the midst of the COVID surge and asked about symptoms of depression, anxiety, and PTSD, and found that about 40% of our workforce had symptoms of one of those three, not diagnoses, but symptoms. So we know this is having a significant impact, and that just adds more evidence, I believe, in making the case that we must continue to pay attention to this. And so if you go to the next slide, you can see a sort of a table that's modified from a paper that speaks to kind of levels of change, commitment, readiness to address this, the issue of well-being at multiple levels. And certainly I think it's worthwhile for every institution to think about, to take a look at and consider where you are and where you'd like to be. There's many ways to do that. And this figure here sort of shows the various levels that an institution might consider being at. It's not about getting to the expert level from a novice level in short order. I think it's more about understanding the range and thinking about where you're at and where you want to be. I can say that I've been doing this work for 16, 17 years now. And certainly when I got started, no one was really paying much attention to this at all. I can say that with confidence. So it's taken that amount of time to get to where we as an organization have given the level of commitment that we're at currently. And, truth be told, we probably could continue to do more. So hopefully this is a helpful way of conceptualizing where you're at and where you'd like to be. If you go to the next slide, I'll just finish up. I think I just have 3 or 4 more slides. It looks like the animation didn't work on that, unfortunately. But what this is speaks to the Charter on Physician Wellbeing, which was written by members of the collaborative that Dr. Menard spoke of, the CHARM group, the Collaborative for Healing and Renewal on Medicine, authored a charter on physician well-being, which was published in JAMA and is captured behind that figure there, which is the landing page for the AMA's the AMA's landing page rather for the Charter on Physician Wellbeing. And that button there in the middle allows organizations, individuals, practices to sign on to the charter. Signing on doesn't require any commitment other than to say that we adhere to the principles of the charter, which basically state that patient care promotes and requires physician well-being. Physician well-being is interrelated with the well-being of the entire team. It's a quality marker, and it's a shared responsibility. While the system probably is going to have, while addressing the system level drivers of well-being is likely to have the greatest impact, we also need to champion self-care and make it a priority for ourselves. That we speak openly and honestly about that. The next slide captures a lot of the evidence that I've been building off of today in a National Academy of Medicine consensus report, which perhaps some of you saw, titled "Taking Action Against Clinician Burnout." It came out about a year ago and is a very sort of an exhaustive report on all the evidence to support why a systems approach to well-being is so important. And the last chapter includes a lot of actionable steps. So next slide, I'll just, this is my second to last slide. I'll just say that, I think we've had to pivot. Certainly in the midst of COVID, we pivoted our experience. And I can remember when, in late February, sort of going through this process of thinking about how, well, we'll probably have to put a few things on hold and maybe continue a few of our initiatives. And then maybe 3 or 4 days later, okay, we need to put everything on hold and think about what's coming. And then within a matter of a few days after that, we realized that we had a really important role to play. And so we pivoted what we were doing in the midst of this. Admittedly, with all that I've said about the importance of addressing the system, in the midst of COVID, it was really important. It remains really important to think about the individuals because now is a time we believe that individuals are suffering, quite frankly, and may benefit more from those individual level interventions, the mental health and resilience building interventions. And yet we do need to shift back towards a systems approach if we're going to address well-being, because again, we know from the evidence that that's where we're likely to have the greatest impact. Incredibly hard to do right now. Never has there been a time that it's been more challenging, I believe, to address well-being on a large system level basis, and yet never has there been a time where it's been more important. One way in which I've been thinking about that, if you remember our model from the beginning, the two major buckets, the two major drivers of system level well-being are culture and efficiency of the workplace. Both critically important, remain critically important, a model that holds true whether it's COVID or not. But some of those initiatives that might focus on those areas potentially require more resources than others. And so if you are facing a time which I imagine many of us are, where resources are tight and these are times of austerity, it's my belief that a focus on culture, that may be where some of the low or no cost options are. Talk is cheap. It's hard to change culture, but the way to do that is actually been shown. It's through open, honest communication and demonstration, usually by those in a leadership position. I don't just mean the top, I mean mid-level leaders, probably mid-level leaders, more important, demonstrating appreciation, showing recognition, being a supportive community has huge impact, probably now more than ever, and can be done without necessarily a large amount of outlay of resources. I put these figures here also to show you some other examples of low-cost interventions that promote a culture at a time such as this as part of our COVID pivot. A lot of attention to the importance of coaching. There's coaching and there's mentoring and there's some overlap, but mentoring, which I think a lot of us are more used to thinking about, particularly in academic settings, is about how can I advise you as my mentee? Whereas coaching is really trying to ask your coachee, what is it that drives them, so you can get them to a place where they're doing the work and they're engaged in work that they want to be doing, that they derive meaning from, where they're really able to have impact. And lastly, the other way to do that is not just with the individual, but with groups, engaging individual practices, divisions, departments in leveraging the resources you have, the clinicians themselves, in trying to listen and understand and then act and develop. It's this model you see here that was shown that by virtue of engaging the individuals themselves who are delivering the work in identifying the problems and suggesting solutions, oftentimes they'll come up with, let's say they come up with 10 ways to solve the inefficiencies of a clinic. 8 of them may simply be not possible, particularly if they require a large amount of resources, but more than likely you'll identify 1 or 2 that are low-hanging fruit. And by going through that process, it's been shown to both improve efficiency and culture. So if you could go to my last slide, I'll just summarize for you that, the approach to clinician well-being, certainly in the midst of COVID, I think I've shared for you, has required a pivot. It's important for us to recognize that this really has been a communal trauma that we've been through. And so we've had some shifting needs and drivers that may lead to shifting priorities. But I would contend that the models we put in place prior to COVID still apply in many respects. I do want to again emphasize how important uncertainty is, because right now, I'm sure many of you can attest, we're feeling a huge amount of uncertainty about what's coming. And that creates anxiety. It's, when uncertainty is the cause, the treatment is regular, authentic, transparent, supportive communications. It really can't be overemphasized. So, I'll leave it at that, other than to say, thoughts about where to from here. I'll highlight again what I spoke to. It's always good to take stock of where you believe your own institution is at. to identify those who you can collaborate with and ally with to make that case to address well-being, as we try to pivot back with an appropriate focus in the midst of the current phase of this crisis. So with that, I'll thank you. I appreciate your patience as we got started. I hope this was meaningful for you, and I'm certainly around for the next 10 plus minutes if we're able to do questions.
Thank you so much, John. That was great and just captured so eloquently kind of the current status and the piece about uncertainty. I think that is so important. Really, really great talk. And again, to everyone, we apologize for the delay when we started. So I'm going to look in the Q&A. And we have a question here from Dr. Kalaki. If not covered, interested in thoughts on the long-term effects of this high anxiety state. Great article on, quote, surge capacity is depleted, quote, addressing why so many of us highly productive people feel awful / hard to focus.
Yeah.
So what do you think about that? Effects of the high anxiety state.
Yeah, I think, well, I know we're seeing that. The reason I know that is because I mentioned the survey that we're doing. So we're measuring it. Others are measuring this. So there's data to support that comment that we are seeing elevation of anxiety. And we're actually gonna be administering we're administering a survey at multiple time points because we're interested in knowing the durability of these symptoms, which my hypothesis would be that that while they may wax and wane depending on what's going on, it's probably just as high right now for all the other elements of uncertainty going on right now. So there's no way to couch it other than to say I'm concerned. I'm definitely concerned. I think all of us in our roles are concerned. It means we have to sort of redouble our efforts at making sure we speak about this. We speak openly about this. October is Mental Health Awareness Month. So we, through my office, are sending out regular messages this month in an effort as part of sort of a campaign to normalize help-seeking behavior, to normalize, reaching out for states of anxiety. I think it's also really important that we think about our leaders as well. I've never seen leaders under such stress for such prolonged periods of time, right? Now, you just hear things from people saying like, I haven't taken a vacation since this whole thing broke out, and this is unrelenting, sort of anecdotes like that. And we have to take care of ourselves, and we have to encourage our leaders to take care of themselves as well, right? I mean, there's only so long that this can be sustained. So, yeah, I was trying to find the positive spin to answer that question. I'm not sure it's there, other than, we need to really be there for each other and look out for our own.
Absolutely. Next question. Curious on thoughts about medicine taking notice of the wellness attention provided by technology companies to its employees. For example, Apple is very forward-thinking in this area. Is there data to support productivity in the tech industry that could be translated to hospital systems?
Okay, I'm trying to think how best to answer that. I thought where it was going first was the use of technology to address the anxieties or to provide resources. But I think within that was also, are there lessons to be learned from some of these other large organizations who may also be paying attention to well-being? I think the answer is yes to both, if those were in fact the two questions in there. There's a great resources, new technologies. I imagine most, if not all of you, are familiar with one or another of the things you can get on your phone and use to kind of use a tool that can promote your own self-care and build your resilience. So I'm definitely an advocate of that. I think there's a lot out there. So it's probably good to go with one that's perhaps recommended by an authority you trust. But nonetheless, there's some really good resources. As far as other organizations outside of medicine, I think yes and no in terms of lessons learned. Certainly, the attention to well-being that some of these organizations are placing should make us all feel like we should be doing the same. They've recognized that there's value in it, that there's return on that investment. Healthcare, on the other hand, is a very different functions on a very different margin than a lot of these organizations, which are these big companies, which can address the issues in a different way. Not to mention while there's some overlap with the drivers that affect well-being in non-healthcare professions, there's some unique drivers as well that influence how we need to pay attention.
Great. And I have two similar questions, which I think actually are more directed towards the wellness committee here rather than you. But how has resident well-being changed in the last 10 months? What's been being done to improve residents' well-being going forward? And then what about wellness time? And just to answer those two combined questions for the group, so I will say for Tulane, we did, the Graduate Medical Education Committee did approve for 4 half-day wellness days for residents and fellows that are not sick days. Your program director should have that policy. That was approved about a month ago. And we really want residents and fellows to know that they have time to go take care of their own preventative health and or those of their dependents or elderly parents, that those days do exist, so they can utilize them. Also, just wanted to add that we have 2 wellness spaces coming, one in the Murphy building and then one also in the Hutchinson building, and we're just waiting for the swipe cards, which we hope to have by the end of the month. But these are going to be quiet meditation spaces. We'll have some yoga mats, again, recharge space or decompress space. So those are coming as well. And so I think I answered those questions. And John, I don't know if you want to say anything about what y'all have.
Very similar. We too have wellness days for our trainees. Really important. Also part of what the ACGME, the regulatory mandate. So that's really critical. And interestingly, the question was about the last 10 months. When we did our survey back in April, actually the residents had fewer of those symptoms that I was speaking to. It was our nurses and our APPs that were really perhaps affected the most. So the residents in the midst of the crisis, at least of the Mount Sinai experience, were perhaps a bit more resilient, or perhaps were supported. And I think it also speaks to how in the midst of crisis, if you're able to feel like you have an impact and you're being utilized, you might actually derive greater meaning from your work. There is this recognition that it's a time where you might have elevation of mood. That was our experience. It doesn't mean the issues with regards to resident burnout and concerns are going away. We need to continue to focus on them as you have at Tulane.
Great. Well, there are no other questions. If there's no other questions, I just want to say thank you. Thank you so much. And it's been great hearing from you. So.
Yeah, thank you all. I really appreciate the opportunity. Hopefully I'm a New Yorker, so I spoke kind of fast in the interest of time. Hopefully I didn't speak too fast, but I really I feel fortunate to have had this opportunity. And I know you all have been through quite a lot down there in more ways than one. So I really do wish you well in the coming months. Thank you.
Thank you so much. We hope to get you down here at some point for a visit.
All right. Very good.
Thank you all for joining.